welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Kelly Bodine, she's the PGY2 emergency medicine resident at Grady Memorial Hospital, and today she's going to be presenting on early adjunctive methylene blue in patients with septic shock, a randomized control trial.
The journal article that I will be presenting today was published in 2023 by Ibarra, Estrada, and colleagues. Just some background on sepsis and vasopressors. So sepsis is defined as the dysregulated response to infection. And there have been lots of definitions in the past few years on how we define sepsis. However, the current definition is the sepsis 3 criteria, which is infection plus organ dysfunction, which is defined as a change in SOFA score of greater than or equal to 2, and that correlates to about a 10% mortality. The Surviving Sepsis Campaign guidelines recommend norepinephrine as a first-line vasopressor, with vasopressin added on if additional support is needed. And this would be for our patients in septic shock, where there is either circulatory, cellular, or metabolic abnormalities that are profound and increased mortality. And this is also defined as hypotension with required vasopressors to maintain a MAP of greater than or equal to 65 millimeters of mercury, or serum lactate greater than 2 millimoles per liter. However, it is also known that high-dose vasopressors increase the risk of peripheral ischemia and tachyarrhythmias. So this has led to a lot of research on adjunctive therapies that we can use to decrease the use of our vasopressor agents. One such agent that has been studied is methylene blue. One of the mechanisms that is thought to contribute to the loss of vasomotor tone in septic shock involves the action of inducible nitric oxide synthase. And methylene blue inhibits inducible nitric oxide synthase in its downstream enzyme soluble guanylate cyclase. And this is postulated to help to restore the vasomotor tone. It is also thought that these effects on nitric oxide occur most within the first 8 hours of septic shock, which is why this study specifically looked at early adjunctive methylene blue, which they defined as within 24 hours. Some of the current literature on this topic is shown on the table. As you can see, these have been smaller studies with the most patient population of 54 patients and the least of 20. And as well, the dosing has widely varied from continuous infusions or just a bolus dose. And these studies have shown that methylene blue may have a role in reducing vasopressor requirements, but it has not been shown to have mortality benefit. So that's where our study comes in today. The study objective was to assess if early adjunctive methylene blue administration reduces the time to vasopressor discontinuation in patients with septic shock compared to placebo. This was an investigator-initiated, parallel, double-blind, randomized control trial at a single academic medical center in Guadalajara, Mexico, which is in central Mexico. Inclusion criteria for this study was adult patients with septic shock, and they utilized the sepsis 3 criteria and the definitions provided in the earlier slides for septic shock. For the exclusion criteria, they excluded any patients that would be contraindicated to the use of methylene blue, or patients with concurrent shock states that would influence the results of this study, such as hemorrhagic shock. The study intervention was methylene blue at a dose of 100 milligrams, placed in a 500 ml saline bag over 6 hours once daily for a total of 3 doses. And to avoid identification with the placebo, which was just a 500 ml bag of normal saline, they were prepared in opaque envelopes. For the primary outcome of this study, researchers looked at time to vasopressor discontinuation, and secondary outcomes included vasopressor free days at 28 days, all-cause mortality at 28 days, serum lactate levels, days on mechanical ventilation, hospital and ICU length of stay, as well as change in serum creatinine, bilirubin, aspartate aminotransferase, and alanine aminotransferase, P to F ratio, and ejection fraction after intervention. For the statistical analysis, comparative data was analyzed using chi-square and Fisher's exact tests, continuous variables via student's t-test or the Mann-Whitley U-test, For repeated measures at different time points, an analysis of variance utilizing the Friedman's test was used. Vasopressor discontinuation, analyzed with death as a competing risk, used the Fine and Gray test and Kaplan-Meier curve, and this was analyzed using the intent to treat analysis. They also calculated the number of patients needed in this study for a statistical power of 80% and calculated that they needed 92 patients. So moving on into our study sample, they did only include 91 patients due to one patient withdrawing consent after the first dose of methylene blue was administered. So this study was not adequately powered based on their initial calculation of 92 patients. The median age of the patients in the study in both groups was 46, and it was majority males with 60% between the two groups. When looking at the norepinephrine doses between the two groups, they don't vary widely. However, investigators did not statistically analyze the baseline characteristics, so it is not sure if there is a statistical significant difference in any of these baseline characteristics. They did note that SOFA score was about 10% in both groups, which would correlate to about 50% risk for mortality. The types of infection present were primarily pulmonary at 49.5% and intra-abdominal at 38.5%. All patients received hydrocortisone at a dose of 200 milligrams a day as a continuous infusion. And vasopressin was also initiated in these patients at a dose of 0.3 units per minute if the norepinephrine dose reached greater than or equal to 0.25 micrograms per kilogram per minute. And no other vasopressors or inotropes were used in this study. So you can see that the methylene blue group had 80% vasopressin use and the placebo group had 74% vasopressin use. All patients received antibiotics within 3 hours. So for adults with sepsis without septic shock, this would be ideal. However, if these patients were in septic shock, as was studied in this study, they would ideally have received antibiotics within 1 hour per the guidelines. When looking at the P to F ratio, although numerically not very different, about 80% of the patients in the methylene blue group and 70% in the placebo group also had ARDS. So for the placebo group, this would be classified as mild ARDS, and for methylene blue group, this would be considered moderate ARDS. So there is a difference between these two groups. And then the maps were not much different, with 68 in the methylene blue group and placebo group of 67. And they also noted that most of the patients in this study got the intervention within 6 hours of shock identification. For the primary outcome of time to vasopressor discontinuation, they did note a statistical significant difference in time to discontinuation, with methylene blue being discontinued at 69 hours and the placebo group having vasopressors discontinued at 94 hours. They also noted that 11% of methylene blue patients and 28% of placebo patients required reinitiation of norepinephrine within 48 hours of discontinuation, although this was not statistically significant. Looking at the secondary outcomes, the secondary outcome of vasopressor free days at 28 days was statistically significant, with methylene blue patients having 23.9 days and placebo patients having 19.5. Days on mechanical ventilation was not statistically significant at 4.2 for methylene blue and 5.1 for placebo patients. Both ICU and hospital lengths of stay were statistically significant difference, and you can see those numbers listed there for the days for each of those. As well, when you look at the difference in lactate levels at 24, 48, or 72 hours, the difference in P to F ratio, creatinine, ejection fraction, the bilirubin, AST or ALT, they did not show statistically significant differences between these values. Researchers also conducted a hazard analysis and found a proportional hazard ratio for shock reversal of 2.7 in the methylene blue group at 28 days, and this had a p-value of 0.0007, so this was statistically significant. They also did note some adverse effects in this study. The first was green-blue discoloration of the urine in 93% of patients in the methylene blue group. However, this is to be expected since methylene blue is dark blue in color. As well, they looked at methemoglobin saturation levels, and this was significantly higher in patients in the methylene blue group at 2.9% compared to 0.5% in the placebo group. However, when based on toxicology data, A methemoglobin percent of less than 15 is correlated with asymptomatic patients. So although statistically higher in this study, it did not correlate to actual clinical outcomes. Now, the evaluation of the study, some strengths. It is a randomized control trial, and the groups did receive similar adjunctive treatments such as hydrocortisone and vasopressin between the two groups, and the largest randomized control trial for methylene blue in septic shock at this point. Some weaknesses: it is not adequately powered with having only 91 patients. It is a single center study, so this does decrease applicability between institutions. And there is a potential difference in standard of practice since this did occur at a single medical center in Mexico. Some conclusions: the authors concluded that early adjunctive methylene blue reduced vasopressor duration, and the results of this study support the ongoing research on the topic. Some of my conclusions were, while the results showed reduced vasopressor duration, an adequately powered study is needed to determine and solidify the use of methylene blue in septic shock, although it may have a role for the treatment in septic shock. And more studies also need to be done to solidify the dosing scheme, since the dosing utilized in this study differed from those used in other studies and has not been consistent among the data that we currently have available. Here are the references that I utilized. And then this concludes my journal club on early adjunctive methylene blue in patients with septic shock, a randomized controlled trial. I'll take questions now.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.